So we're continuing with the lecture series for the residents, and so today this is the first time we're gonna be talking about the brain. So we're gonna really speak about very basic brain findings that you need to know before we go to the deeper ones. What we're gonna do when we get to the pediatric neuroradiology section of the course. So so this is just kind of to understand the same way we did 2 months ago, how the spine kind of develops and you get the main dysgraphisms happening. What's going on with the brain? How can we approach these? These are a lot of things that you're going to see in life, but also in board. And you need to have some clarity. So I have divided this into the supratentorial region, and there's a completely different section because the development of the infratentorial region in the posterior fossa is a chapter of its own. It has a lot to discuss. So we're going to kind of focus on the main things, and we will not go deep into details like developmental, some of the developmental injuries that deal with epilepsy, for example, because we're going to have a separate chapter where we're going to be doing an interactive review of that. So let's test your knowledge like always. So let's start with these 4 cases, and so this is the first one. Like always, just write them down if you want. Just see if you know what you're gonna say, and at the end we'll review them again and see if we were right or we were wrong. It's the second case. This has a little more stuff in it. Try to look for more than one thing. You're going to see that a lot of these cases have more than one finding. Case 3. Just in case you were wondering why you have the frontal lobe there, take a look at these vessels. These are going to be important for the diagnosis. Case 4. This I used to miss a lot when I started reading because symmetric
People are
disease.
still missing the.
Right. Symmetric reading is symmetric lesions are so easy to miss when you don't know what you're looking for. And now this one, right? This is a board question. If you don't get this one right, doesn't matter. You're gonna get it right at the end of the lecture.
After the Supreme Court ruling.
We'll get it at the end. So let's take it easy. Just let's tell the tale. Let's see what we're going to talk about today. And again, we're going to basically concentrate first on how the main cortical organization happened. I'm not a geneticist. I don't want to be one. I'm going to tell you the way that we read it for our neurosurgery colleagues in the room and the pediatric neurologists that are also on Zoom. We want them to speak a little bit about cortical migration defects, the main ones, and sulcation. And then we're going to talk a little bit of the prosencephalic development and how, and we're going to definitely talk about holoprosencephaly. That is kind of the main one, but we'll also talk about other diseases that are very similar to them, like septoptic dysplasia. So let's start everything with the neuroblast. So the neuroblast has, of course, like any cell, it has a body. It's going to be a pre-neuron. It has a body and it has an extension. Imagine it has one little axon that goes up there, and they start to organize themselves in a circle. So they all create a circle. They're very happy. And all of the bodies are kind of around the inner part of the circle, and all of their extensions stay in the periphery of that circle. And a bunch of them start to uh, organize around what we're going to know as the neural tube. And that's how that neural tube is formed. So we have a center that will have an ependymal lining, and then you have an external part, which is mostly white matter. It's all these extensions that you're going to see there, and that's true, and it keeps true for the most part when you go into the spinal cord, but it doesn't happen in the brain or in the posterior fossa. Where are my click? Okay, so those slides are. So this is just how you're going to see it in the embryology text of the neural tube, is that is neuroectoderm is going to organize into what they call the ventricular zone, that has this germinal matrix that has the glioblast and the neuroblast. Then there's an intermediate zone, which is the mantle zone. And then you're going to have the margins, which is the marginal zone, which is mostly the white matter. So this is just fancy words for the same organization where you have all these somas of these neuroblasts are going to become the gray matter, and where you have all these extensions is going to become the white matter. So what happens to the neural tube? So when it comes to the more cephalic portion of the tube, you're going to see it like we're going to split it up. And if you want to split it up and kind of cut it in a coronal view, that's how it looks. We have a big tube, and it has two strictures, and these two strictures are going to give you these primary vesicles, which today we're going to concentrate on the top one, which is the prosencephalon. This one is going to divide into these it looks like a Mickey Mouse if you see that there. The diencephalon down here, and these two big ears, which are going to be the telencephalic extensions. And if you look at a mouse, this is how it really looks like, right? So this is a mouse brain, not a Mickey Mouse, but it really looks like that. And you see how there's an organization of gray matter that is just around this ventricle that is in the middle, this big central ventricle. And the diencephalic region is going to become the third ventricle. And then the telencephalic holes, if you may, are going to be these lateral ventricles, but they're all lined very, very nicely by these somas of the neuroblasts. So this gray matter that is involved in all the way. Then you have these kind of lighter ones that I put there, which is going to become the thalamus. And that's why you see that the thalamus is in the floor of the third ventricle, but it's also in the walls of what is going to be the floor of the lateral ventricle, and then the walls of the third ventricle. And then you're going to see the hypothalamus just develop inferiorly. So how does that kind of start, and how do we get a cortex? So we start doing migration pathways that are left by the glial and the axonal development that happen afterwards, and they start just going into the periphery and creating in waves the cortical organization. And what happens when this happens, this is very basic on that, is that you lose all of the gray matter that was around the ventricular system. And you only have gray matter kind of in the inferior aspect of the lateral ventricles, while you keep all the gray matter around the third ventricle. They're still connected, and we're going to see how that connection then evolves. And they're all surrounded by this ependymal lining. So you lose all the cortex here. You should not have any cortex in the white matter. And then now you have the gray matter all organized in the periphery. And that's basically what we need to learn. But this doesn't happen the same way all the time. So let's go a little bit about in cortical organization. So what happens if you're trying to migrate them, and these waves of migration, and these migration waves just get stuck where they were originally. So they become these clumps of gray matter that you're going to see directly in the periventricular white matter. And this incomplete arrest is what we call periventricular heterotopia. And that was one of the cases I showed initially, right? So these are the ones that they tend to be kind of hard to see because they're so symmetric. But you see that there's a nodular abnormality around the ventricular system. And as we said, we should not have any gray matter in the lateral or superior aspect of the ventricles. And you can see also that they're going to follow on T1 and on T2 the same signal intensity as the rest of the cortex. So we should not have flare hyperintensities. We should not have anything else. They look this is just normal neuroblasts that got arrested in their migration. And this is periventricular heterotopia. These, believe it or not, are one of the easiest to miss because again, we don't have very clear what the morphology of the brain looks like. It's very easy just to say it's normal. So look at that. And as you heard Dr. Tandon say, they're still missed a bunch. Now, what happens if they get just tired of migrating and they get arrested in the middle of the way? This also tends to be very common and in a symmetric fashion, like in the previous one. And this will create these bands of just arrested gray matter that is going to be in the middle of that way. This is what we call band heterotopias. These are a little bit easier to see because you really do not see the white matter being white on T1. And we all know that we want to have nice, just sheets of white T matter on T1. When are they easy to miss? They're really easy to miss if we don't do it. If we do it early when the patients are not completely myelinated. So when you don't have complete myelination, it's very easy sometimes to miss this. Yes, you're going to say. I thought David, you want to say something?
I was not.
No,
Just listening.
no. So it's very easy to miss if you don't have complete myelination. And T1 myelination, we're going to have a whole lecture of Dr. Patel on this. Happens typically by 12 months. So at the end of 12 months, you should have complete T1 myelination. By the end of the second year, 24 months, you should have complete T2 myelination. These are kind of very easy landmarks to remember. So before 12 months, sometimes it's very tough to see this because you don't have a nice contrast between the gray and the white matter. So I'm sorry, this came just too fast. So band heterotopias, remember, tend to be symmetric, and they tend to also come with sulcation anomalies. Band heterotopias are also very closely related to some of the Schizencephalies. And when we get to Schizencephalies, we're going to see that as well. So some of those are also involved. So now let's see what happens if the cells are just migrating, right? But when they reach where they need to reach, but they do not organize in the right way. So if this is regular cells that have the same signal intensity, but you just have like they're clumps of cells that didn't organize right. And that's what we call cortical heterotopia. So it's kind of the same thing. The arrest is kind of when they're organizing up here. These are much tougher to see because if you don't look carefully at the sulcation and carefully at how thick the cortex is, you can miss them. They tend to, when you see them, the sulci tend to be very shallow because it's just so thick, it doesn't allow for the normal gyration. Or instead of being shallow, you can have multiple very small sulcations that are not normal, which we would call polymicrogyra. So these cortical heterotopia, that is because of migration, remember that they will have abnormal sulcation, and it's just the same disease, just the organization of the sulci is not going to be the same. They tend to also to be bilateral. So when you have one, look always for the other side. As you can see, there's also in this side. And when we're going to talk about epilepsy, you should never just give up when you see one migrational defect. You just have to look at everywhere because sometimes you have smaller foci that you could miss just because of satisfaction at search. And a lot of the times, it's the small ones, the ones that are actually acting up, and not the bigger one that you need to do. And we see that a lot when we do the EEGs and the functional, which are the foci that are really targeting then afterwards for treatment, because they're the ones that are responsible for the symptoms of the patients. Now, this is just another cool one. There's a lot of theories on this, and I think the main theory they still have is this could be a vascular anomaly that happened when they were migrating, and then the glial cells that told them where to go just couldn't go all the way, so they paved this kind of little pathway with gray matter that is connecting the ventricle all the way up. And that is what we call schizencephaly. And I think the main thing to remember when we look at schizencephaly is to remember that schizencephaly, the defect that will not connect to all the way into the subarachnoid space, right? It connects us to the subpial space. So that's why you can have schizencephaly, even though you have a huge defect that looks like it's open, the patients will still have hypercephalus. These are not connected with the rest of the CSF. There's actually, they left this little membrane there. These are the drawings when I was like 80 years old. That's where I stopped. But that is a very important part of this. So this is how you look at schizencephaly. It's tough when they're little, but then if you will see the cortex and you watch carefully, you're going to see the schizencephalic defects there. They can be, as you all know, open lip or closed lip. This is it just depends if there's CSF around them or not. If you want a real clue, if you want to see them and you're looking at them and you're not sure if this is a prosencephalic cyst, which means dead brain because there was some sort of anomaly, always see if there's a little vessel in the middle. If you see a little vein in the middle, it's going to be typically a schizencephaly, right? You don't get those with prosencephalic cysts. But sometimes it's really tough. Especially when the kids are not myelinated, I have such a hard time really looking for that nodular pathway. But you're going to see them, and they're associated with other defects. Some are with accidentally with septoptic dysplasia, and we're going to talk about that type of septoptic dysplasia later today. So,
Roy, isn't the rule of thumb that if there's no cortex lining the boundary, then it's prosencephaly? If there's cortex lining it, then it's schizencephaly.
Right, but if you don't see it, like for example, in this case, sometimes it's not clear. Sometimes you're trying to see the cortex and it's just not there. So another clue would be the vein. The vein is kind of a second thing that we do. It's I wish that they all read the books, but yeah. So when schizencephalies are like this one, when you have this very thick nodular heterotopia, it's very easy to see. I find myself a lot of the times with these very thin ones that you're not clear if there's cortex in there. I don't know, Kate, if that's the case for you, but that's something we see all the time. So this is an open lip. Remember that this is Pia right here covering this. So there's no communication. So these are open lip and closed lip. And then it can be associated with other things, as I told you. And we're going to talk about septoptic dysplasia, but just as a reminder, you do not have here a septal hallucination, as you can see in this case.
Is there any clinical repercussions of closed lip versus open lip, or is that just radiological?
It's just the way they look. It's just the way they look. So with this, we end up. That is what I had for cortical migration mostly. So now we're going to talk a little bit about sulcation anomalies. And I will not spend a lot of time. This is kind of a 101 when you're doing a brain anomalies. I think the biggest thing that we're going to talk, and I'm going to say it 3 times today, is you should not ever try to detect or say there's a sulcation anomaly if you don't have a corrected gestational age. That is the worst, I think, problem when we're doing that sulcation. And when we have, is this underdeveloped or not brain? Is the sulcation right or not? You always have to check for gestational age. We're having babies at 24, 25 weeks, right? So they're going to be kind of between this and this stages, and it's still completely normal to be undersulcated because they're alive and they're out. So you have to be super careful when somebody asks you if there's a sulcation anomaly, you don't know that just the correct gestational age. That goes for a couple of other defects, but this one is very important. So usually the fissures that you're going to have from 14 to 17 weeks, you're going to have the paracipitral fissure. You're factory sulcus with a single sulcus. There's very little sulcation that you should see in the first 17 weeks. Now, at 22 weeks, you start seeing the Rolandic sulcus. And some of the parahippocampal gyrus and the superior temporal gyrates are going to be seen. We don't have babies born at this. We see this a lot when we have do fetal MRIs. This is kind of the fetal MRI time when we see them. But when they get born as very early in life, we see these periodontic fissures with the middle temporal sulcus, and pre and post Rolandic gyrite are going to already be seen. And only after they are 26 to 29 weeks, you get the inferior temporal sulcus, the inferior frontal sulcus, and some of the temporal gyrus and the triangular gyrus being formed. So remember that is going to be very important. So here you have a sulcation anomaly. And what you're seeing in this sulcation anomaly is that you have decreased sulcation. And is it completely smooth? It's not. But it's under the sulcation hasn't happened. What other defect do you see here? In this case,
No corpus callosum.
you cannot see it. This is a parasagittal
No.
of what we already saw today. That we said that goes with under sulcation.
Adaptive.
The cortex is extremely thick. You see, this cortex is extremely thick. So this patient has diffuse cortical heterotopia. See how I told you you're going to miss one? It's very easy to miss. When you look at symmetric disease, it's not easy. We're all concentrated and looking at symmetric. Look at its asymmetry on the left side, but it's very thick. It's under sulcated. This is how sulcation should happen. So this is oliguria, which is that you do not have enough sulcite. So remember that about the corrected gestation rate I put there, but you're going to miss them if you don't know this. This is from one of our papers in the American Journal of Radiology, is that just to show you that in fetal ultrasound, you can detect severe cases, but a smooth cortex can be normal in fetuses up to 26 weeks of gestation. So when you have very, very early babies, you could see this, and you're going to call that Schizencephaly. It is not. And so you have to be extremely careful with the gestation rate. They wanted to bring that because this layer that will be dysplastic should not happen. Now, this is a patient that is already myelinated. This is a 2-year-old. And you see that it actually is super smooth. And this is the typical Schizencephaly. They call it the hourglass sign. You see why in actual it really looks like there's a stricture right in the middle, and that you have the frontal and the parietal lobes kind of separate. But this very thick, and this also has heterotopia. This is just diffuse migrational defect that goes with the sulcation defect. There are two types of Schizencephalys. The other day I was reading this. I didn't update my lecture, and they called it type 1 and type 2. Now they just called it the ones that are heterotopia, and the other ones are the that we used to call the cobblestone, are the ones that are associated with torch infections. They both give you under sulcation, but they're extremely different. So these ones are very smooth, and the cells never migrate past the lamina terminalis. When you have it associated with CMB, the cells are going to give you this cobblestone appearance. They're still under sulcated, and you're going to have other findings such as these calcifications that happen in the perventricular white matter. So the ones associated with torch are usually in kids that are microcephalic. You're going to see the cobblestone appearance. When you see them in live, the brains of people of the kids that have this looks like little cobblestones in the under sulcated brain, and they're also called Schizencephaly. They figured out these are completely different diseases, but they're both extremely under sulcated brains. So remember that and be ready for that. So we saw the sulcation anomalies, and we're going to end up with the prosencephalic development. So we saw these diagrams before, but this is kind of how I imagine them looking. I'll show you actually how in microphotography they look. So these are the three protuberances with the two strictures, and you have the prosencephalic protuberance up here. This is the one that we're going to be studying, which is going to be that prosencephalon is going to be split into the telencephalon up here and into the diencephalon down there. So the white matter is going to be crossed in the telencephalon by the gray matter. But the gray matter of the diencephalon is typically going to be gray matter that is less dense. The decreased density of that gray matter is going to make the thalamus look a little bit clearer when you cut it or when you scan it. It has a lot of more white matter tracks around it. While the bottom part of the telencephalic gray matter is going to give us the striatum. So it looks more like the cortex. It's about higher energy. It'll give you the putamen, and it's going to give you also the caudate nucleus. And we're going to talk about it later. So let's kind of go through this and see how we created from these three protuberances up here a fetus. It never makes sense to me. So in 2 months ago, we saw how we created the whole tube. So now let's create from a tube. This is folded like if we were creating a croissant. Right? And you start folding it until you get something like that, right? You just folded it, it's a craniocervical, so it's folding, and that creates finally, you just put a little bit of brachial arches there, and that's how you create an embryo, right? So an embryo is just, you grab the tube and you just fold it like if you were creating a croissant, and you have this prosencephalic protuberance here, and this is the one that we're going to be studying today, and of course, the tail, which is the most caudal part, which we saw in the disc raphisms. These are how the vesicles actually look like. And if you see them in a mouse, these are not human embryos, but in embryos. So this is how the protuberance looks like. These are the little strictures that you see, and they finally this is, you have to have a lot of imagination to just put this elongated the way they show you in books. But this is how it really looks like. These are the telencephalic protuberances. Right, this is the midbrain, the mesencephalon, and this back here is going to be the rhombencephalon that we're going to be. This is the rhombencephalon, which we're going to be talking about in our next lecture. So let's talk a little bit of what happened to the prosencephalic development. So we had this Mickey Mouse structure. We already migrated it, and we knew it was normal. We said that the gray matter from the telencephalon is going to become the striatum, and that the gray matter of the diencephalon will of the thalamus and hypothalamus. We start maturing and making a nicer shape that looks more like a brain. And we start having new white matter structures that are crossing from anterior to posterior. One of them is going to be the fornix, which is part of the archibrain that we have. And you see the fornix there. And finally start having fibers that start crossing from left to right and doing your commissural fibers. So when the commissural fibers happen, and the commissural fibers happen as we're splitting this big telencephalon into cerebral hemispheres. There's a disconnection of the gray and the white matter that happens between that and the fornix, and that's what's going to cause the septum pellucidum. So the septum pellucidum is actually gray and white matter layers that are kissing each other, and that cavum in the middle, that famous cavum septum pellucidum, is really not a ventricle, because it was the space that was in the embryonic interhemispheric fissure that got stuck there because the corpus callosum developed. So today we're going to see a little bit of callosal development of septum pellucidum. Remember, the septum pellucidum was gray and white matter, and of the fornix. And after they form, the ventricles give you this nice triangular shape in the frontal horns, just at the level of the foramen of Monroe, and you see the foramen of Monroe is going to be then its limits are going to be the fornix medially and superiorly, and inferiorly you can have the thalamus. That's how you communicate these lateral ventricles normally with the third ventricle. So let's see when this doesn't happen. What happens to this? So holoprosencephaly are just a group of forebrain malformations. There are multiple. Now that we have genetic information, we know there's a tremendous amount of them. There's a failure of development of the brain and to have normal cleavage of the brain into these distinct hemispheres. In all of the forms of holoprosencephaly, you will have an absent septum pellucidum. You need to know that, all of the forms. So you have to look for a septum pellucidum. So as you're developing the brain, which looks like that, the cleavage defects can be from no cleavage at all to almost complete cleavage. And depending on that, you get that spectrum that we call alobar, when you cannot define lobes, to semilobar. I'm going to talk about the types of semilobar that are going to see. And finally, when it's almost normal brain, you call it lobar. And what is the difference between alobar and semilobar? It's a spectrum. You cannot just define this is definitely one over the other. One of the things that there was a beautiful paper wrote like 35 years ago that says that the face follows the brain. So the worse the cleavage defect that you have in the brain, the most likely you're going to have facial anomalies. So if you see a patient that has hypothyroidism or extreme hypothyroidism like cyclopia, or the nose is really not split in two, all of these defects are following extreme brain cleavage defects. So you have to remember that. Well, lower defects really do not have a lot of facial defects. So they kind of go together. But these are the three main ones. The clinical presentation varies depending on the degree of cleavage. And this is what I was telling you about the facial anomalies. So the severe forms typically will have some of this. If they're really severe, they have much higher rate of abortion. So what are the causes of it? You can have chromosomal causes, unknown causes, and environmental factors. I found that this is very interesting. So the cleavage of the brain could be associated with trisomies, deletions, duplications, or partial monosomies, but it can also have environmental factors. So maternal diabetes, patients that have been ingesting retinoic acid, the mothers, fetal alcohol syndrome, CMV, toxoplasma, rubella, and anti-epileptic medication in pregnant patients, they all can give you cleavage syndrome. So these are a different type of syndromes, and they can be genetic or chromosomal or environmental. And I think that this is very important to take into account. And this is one of the main things that you're going to be seeing in patients that have a documented baby that has this. You have to look for these causes. So let's talk about associated anomalies. So all types of holoprosencephaly, regardless of the severity, they'll have an absence of the septum pellucidum, right? Some of them will have just a genesis of the septum pellucidum if they're lobar holoprosencephaly. It's not complete, but just partial. We're going to see how that can happen. And various degrees of the agenesis of the corpus callosum can be seen when you have that, because the corpus callosum is made out of that. So here you can see the typical longhorn. We're in Texas, we have to talk about longhorns. You can see the typical longhorn appearance of an absent septum pellucidum. This is the face, and here are the big longhorns, because there's a partial, you say that this genesis of the septum pellucidum in this case. But this is a kid that also has very big atrium and posterior ventricle, part of the ventricle, because he has some colpocephaly. And this is associated now, you can see here also with a lipoma. So when we're seeing them, holoprosencephalies and fetal MRIs, you don't get to see those a lot. But this is how they look like. You'd have, look, this really looks like those diagrams I was trying to show you. These are very smooth brains that already have a cortex, and you can see the thalami in the middle. One of the things to remember when you're looking at alobar holoprosencephaly, independent of the size of the ventricles, because it's going to be very important to see, because sometimes extreme hydrocephalus can be confused with this, is that you have to have thalamic fusion. There is thalamic fusion in alobar holoprosencephaly. You will not have that in any of the other forms of extreme big cysts in a newborn. So the first thing that we look for is to see if the thalami are fused or not, because it's very tough when they're already, when the patients are older. Give me 1 second. To see them or not. The case I brought was one of the ones that I brought in the initial, the case number 5, that was clearly a case of a lower holoprosencephaly. And we're going to review it at the end. Let's go to semi-lower holoprosencephaly. In semi-lower holoprosencephaly, typically the anterior regions of the brain are fused and they're underdeveloped. And there's kind of this incomplete separation of the ventricles. If you ask me, and this is just me, but everything looks like something from Batman, right? When you look at the atrium of the ventricles, it looks like you have the Batman wings, and everything is just a monoventricle. It looks like the saying of Batman. And when you look at the posterior aspect of it, it somehow resembles the same thing. It looks like there's something anomalous in the middle of the brain. There's no septum pellucidum, but it really doesn't look normal at all. There's lack of fusion of the anterior aspect of the brain in all of these cases. And that's semi-lower holoprosencephaly. There are two types described, an anterior, a middle, and an anterior. It really doesn't matter to you guys. It's just remember that if you have a monoventricle with no septum pellucidum, it doesn't look normal, you're going to call it. So now we have this thing called as Schizencephaly. There you go. This kind of a new one where it's only the posterior and frontal parietal regions that are going to be fused. It's only those. And one of the reasons why this is different is because it's usually associated with an azygous or nazygous anterior cerebral artery. It doesn't make a lot of difference. It also comes with a lot of migration anomalies. But this is kind of a type, if you may, of the semi-lobar holoprosencephaly. And then this one, which is I think the toughest to diagnose, is lobar holoprosencephaly. It looks really like a normal brain. It's amazing. It looks like a normal brain, but then you see that there's no septum pellucidum. But one of the things that you have to look for is for the fornix. If you see fornix that is fused, this is one of the real signs that this is going to be a lower holoprosencephaly. And why is it important to know if it's fused or not? Because there's another disease that looks very similar to this one that is very different, which is this one. See, this looks so similar. I'm going to put them side by side. There's no septum pellucidum, but the fornix is not split. And then to the next thing you have to look for is right here at the optic chiasm. In the first one, the optic chiasm is here, and you can really see it. I'm going to blow it up in a second. And here you cannot see the optic chiasm almost at all. And they both have absence of the septum pellucidum, right? But the pillars of the fornix are not fused. So these two, if you can spot the differences between two, they look so similar. But this one that has a very small optic chiasm and does not have a fusion of the fornix, this is the medial type of septo-optic dysplasia. Very different disease. It's kind of a cousin of the holoprosencephaly. And this one that has a complete normal optic chiasm, but you see this thick fornix. It's a very thick cord that is the fornix. You see it like this round thing there. This is lower holoprosencephaly. These are tough, but if I was going to ask you something, I would show you these two images so you could see the difference, because they're completely different cases, and they're based mostly on looking at the optic chiasm. So I'll send you this, but if you want that, this is just my cheat sheet to see what type it is, which one have monoventricles, which have fused thalami or not. But you have that in this table. You see that the basal ganglia being fused is typically of the alobar. The semi-lobar sometimes has it. You don't see it all the time. But when you have big defects, always look for the thalami. I think that's what's going to be the most important thing. And I guess when they're lobar, they're almost normal. Or it's optic dysplasia, I would definitely go to the fornix. The fornix is going to become the key there for you. And now we're going to finish here with corpus callosum. It's almost done, and we have all a headache of looking at my drawings. So let's see what happens with the corpus callosum. So as the brain develops, in Latin, thalamus means bed. It's in the middle of everything, right? That's where the thalamus is, and it has a little pillow which is pulvinar. That's why it has a pillow of the thalamus is the pulvin. Everything starts developing around the thalamus. So the telencephalon that we saw that is here has to grow, and the only way it can grow, it starts growing posteriorly. It goes posteriorly and it creates the parietal and the occipital lobes. But when it needs to keep on growing, it doesn't have space ventrally because you have the brainstem, so it has to go around the brainstem and keep on growing, and that's where the temporal lobe starts happening. And that's why all of the structures that you see in the brain have this C shape, which is a C around the thalamus. And there's so many C-shaped things. The ventricles have a C shape. You know, the fornix has a C shape. And the corpus callosum almost has a C shape. It's a semi-C shape, and that's how it develops. So just as a reminder of how that is going to happen. If it doesn't develop, it's in the genesis of the corpus callosum, it's going to give us very clear, distinctive things that we need to see. So one of them is this bullhorn thing, but I told you where Texas, it really looks like a bullwinkle to me. You know, you see that where you have a high riding third ventricle because there's no corpus callosum. So the third ventricle rides very high, and you do not have a septum pellucidum clearly, and so the fornix are kind of split sideways, and these lateral horns are actually the lateral ventricles, and it gives you this kind of moose or a wolf shape. You can see it all the time. You know, it's amazing. Once you kind of get this into your brain, you start seeing it in both coronal and axials. It's going to be very tough not to see, but it's not always easy because we didn't have, when we started doing all of these studies, we didn't have sagittal views much. You know, MRI came later. We were doing only axials. So we have all these other signs that are in cross-sectional, mostly in the axial views. But now that we do this all the time, this is kind of, they call it the rising sun sign, which the sun is going to be the thalamus. And all of the sun side, since you can do a C shape to give you the cingulate gyrus, which is also C shape, you have all of the sun side kind of a rising from the thalamus that way. And they're all oriented radially from the thalamus when you have callosal anomalies. There are two things that are associated with callosal anomalies. One are lipomas, and the other ones are cysts. Cysts are a lot more frequent, but I just find it amusing to see the lipomas because there are two types that have been described. If the corpus callosum really did not develop at all in a C shape, you get this tubonodular type of lipomas. You have to be really careful because they can be tricky in a board question or in your patients. You cannot confuse them by bleeds because they're right on T1 and they can extend into the ventricles, as you can see. So be very careful. And what you have to do to avoid this from being mistaken, confusing them with intracranial bleeds is look at your fat sac. You know, look at your fat sac. But these can really be confused with these are tubonodular. But if the corpus callosum almost develops normally, you get this ribbon-like lipoma, which is just follows the corpus callosum. And these are kind of the two types that you're going to see: the bulky tubonodular or the ribbon-like, which is called the curvilinear. And so this is what we saw today, right? We went through the cortical organization, to the cortical migration and sulcation, and with the main the prosencephalic development anomalies. We will go deeper into this when we go into PD. And again, I'll have a completely separate one for the posterior fossa, which is a chapter of its own. So let's go to the cases to see if we could identify some of them. So this one, now this is where you guys start talking.
Dallas, you wanna crack?
Cortical heterotopia.
Okay, so we have, is this the cortex?
There's periventricular, but there's also like nodular heterotopia on the
Okay, so
Cortex
where's that heterotopia?
coronal. On the coronal.
Say that again?
On the coronal, there's like
Right, so it's heterotopia because it has the same T1 and T2 signal as the cortex. We agree on that.
yeah,
Is it in one side or in both sides?
mostly one side, just that right frontal.
Look at that. You also have it on the left. So remember, you all just have to look for other defects, right? And did we say that it was typical to see heterotopia that goes from the periventricular white matter to the cortex? No. Remember we said it was periventricular, laminar, or cortical. this one is in all three. So what do you think could be happening?
Schizencephaly?
Huh?
Schizencephaly?
Yeah, so this is a closed lip schizencephaly. And you, why can't you see it? Because it's right there, but it's closed lip. So you don't have to see that, yes.
So is this right-sided schizencephaly with left-sided cortical hypertrophy?
With right-sided, I think it's more than cortical. I think it's in the white matter, right? Like white matter heterotopia. But this is closed lip. This is very easy to miss, but this is just a schizencephaly.
And the cortex that lines it is dysplastic as
Right.
well. Polymicrogyric.
This one. This is a toughest of them.
Many things, right?
Yeah.
Just name them.
So you just look at the bullhorn, right? What is it?
This is corpus callosum dysgenesis there. There's
And what is that? I told you the two things associated with callosal dysgenesis you have to look for. Cysts
yes,
and lipomas. They typically are associated with cysts, okay? Interhemispheric cysts. Okay, so you got that.
I mean there's some cerebellar genesis as well. There's posterior processes.
We'll get to the posterior falls in next lecture. Don't worry about that. Let's continue to let's keep up in the supratentorial region.
Some Prosencephalic.
So you see all,
Holoprosencephalic.
Huh? So there's a bunch of migrational defects.
Yeah.
There's a bunch of migrational defects. These are a little bit more complex, as you can see, because they are not following the brain. This is cortical dysplasia. We're going to talk about the dysplastic syndromes when we do epilepsy, but this is clearly a callosal dysgenesis. I think it's almost completely gone. You see the kind of the horns of the bullhorn here, but they're always associated with cysts, or not always. A lot of the times associated with cysts or with lipomas, and they don't come alone. This one has a lot of cortical heterotopia and anomalies with some dysplastic frontal white matter. So if you kind of know these rules, it's gonna be easy to talk. If you go to a geneticist, they're gonna go crazy with when we speak to them, because they're gonna say, "Oh, this is whatever mutation." But what we really need to know are the big things, and that's what we're gonna be treating in the patients, right? I think that's what you're gonna be seeing in the boards. This one.
Roy, exactly a great point. I suspect there's gonna be some recharacterization of these words based on the genetic pathway.
The Barkovich book has multiplied 3 or 4 times in the last 10 years. It's like everything that's a new syndrome route. But we still need to have a classification that we can speak clinically among each other and understand what I don't think that we do.
Well, the issue though is that understanding the genetic basis then helps in many cases guide anticonvulsant therapy, helps guide prognosis. You know, if you can, so this is, if you will, the phenotype, right? But it's
Right.
the genotype that dictates their clinical behavior. This is a snapshot in time. So I think, you know, there will be that sort of like, how do we meld these two different things together?
I think that's
So
the
we can really
future.
prognosticate.
I think that's the future, and I think that we will be able to match phenotypes and genotypes very soon. Yes, how are we gonna do it? I'm not sure. I'm not sure how we as clinicians that are not doing that all the time, we're gonna speak about it, because most of all, you're treating the urgencies or things that you can do in the kids if you're not doing genetic therapies or things like that.
Yeah.
But yes, I completely agree. This is kind of how we do the bread and butter. But yeah, you're absolutely right. So what is wrong with this? This is a tough one.
Okay, you wanna take it?
I think it's mild lobar holoprosencephaly. There's
Right, so
hypotelorism and
there's no what?
fused cephaloma.
So the corpus callosum, the cephaloblossom is not there. But when you see the corpus callosum, you follow it, see how there's a big mass there, the fusion of the interior aspect of the brain. And I just brought this to show you that there was no azygous vein here. So this was that variant that I told you that I cannot even say. So, but if you have that variant, you Schizencephaly too.
Which animal has a single A1 or single anterior cerebral artery? Anybody?
It's equine.
Every cerebrovascular neurosurgeon loves asking this question, so
It's a
sorry
key
it's coming from me.
Key question, you gotta know.
Yeah. And
Now they have 7
The horse, equine.
of course, I don't know what other animals besides the horse, but Jacques would know this, of course. The zygus anterior cerebral artery.
We're now talking about animals.
Oh, I see. Besides the horse?
Okay, so this one, case 4, we're done, guys. Case 4. I told you about it. I told you it was case 4. So this
You
is.
see a lot of this.
The ventricular. These are the ones that are easy to miss. When we are rushing for in Nathan's cases, I can see how we can miss them. They're typically got, sometimes you just have little spots here and there. And those are so tricky. They're extremely tricky if you don't know what the patient is having and where it's been triggered. Sometimes it's not easy, but this one is just plain. You can see how nodular it is. You still have cortex, right? But you see there's thinning of the cortex up here. So not all of the cortex is normal. Remember, it always follows the cortex in all sequences. And in this one, right, there's a big pancake there. So you look at the fusion of the thalami. I brought you guys to look at that. So sometimes you can, when you have strictures of the aqueduct, you'll have this huge cyst. You have to make the difference. You have to look for this. You have to see if the thalami are fused or not. Because unless they compress them, it's going to be very hard to see if there's a mantle, if there's not. You're going to be kind of all over the place. So looking for fusion of the thalami is going to really make it easy to know you have an halo or shaped form of holoprosencephaly. And I think that's it. So we're going to continue with posterior fossa next time. Are there any questions? So I hope that we got through, cortical anomalies of migration, holoprosencephalies, corpus callosum, development anomalies, and sulcation. These are kind of the main frame. And when we start doing congenital disease of the brain, then we'll get to the more juicy and hard ones later. Thank you so much.
Thank you.